And we're back with Marc Surdyka. Marc, how you doing?
I'm doing well. It's good to be back. First time in the new office for everyone who doesn't know, which is probably everyone listening. Nicole and I moved to Phoenix, Arizona, and now I have a nice dedicated office. So I'm trying to get it set up for podcasts, YouTube videos, and just for my own aesthetic.
Yeah, we were just talking before the recording on how to evolve our current work rooms and offices. And I've mentioned this on previous episode, I believe, but I just recently moved down to Albuquerque. So we're both in new places. I don't know if it's like from where I was in Washington to where you were in LA distance wise versus Phoenix now to Albuquerque. Are we essentially like the same distance from each other?
I think we're closer now.
Sick. I'm going to drive up. What are you getting, or what did you already buy for your living room?
We recently got a shuffleboard table, so great for entertainment.
Have you played
Um,
Nicole yet?
yeah, of course, got to win, no mercy. And for people who don't know, I grew up in Yuma, Arizona, and then I went to undergrad at Arizona State University, ASU. So Nicole and I have been living mostly in Los Angeles for like the past 7, 8 years. We went to grad school in Atlanta. We lived in New Jersey for a year. We lived in Tacoma for a year, but most of our time as a married couple has been in Los Angeles. But yeah, we're in Phoenix now, about 10 minutes from my brother and his family. So it's been nice.
Nice. We are going to dive into the total knee replacement blog and YouTube video that, as of this recording, would have come out. Both of those would have come out a few days prior. I wrote the knee replacement blog, and then was it you or Tony that ended up filming the knee replacement video?
Well, we filmed it together, but Tony was the one who kind of took the lead on it. So yeah, he basically turned your blog into a video. So, small modifications, but trying to stay true to the content that you created and the research that you dove into in that blog.
Yeah, so today we're going to kind of elaborate on both of those pieces. And the goal is for clinicians to have a resource on total knee replacement, rehab, and the process, and for clinicians to send to patients or people who are leading into a knee replacement, considering a knee replacement, going through the process already. What I wanted to dive into prior is our piece on osteoarthritis on knee OA that came out about a month or so ago, and the most recent, or one of the most recent episodes on knee OA from the podcast with Alana Ackerman. So we're going to dive into the process of knee rehab after TKA, but I want to at least summarize or touch on some of the things that people should consider before a knee replacement that can be helpful as a discussion points for patients, and to maybe think of, is this an appropriate time, if I haven't already, to get a knee replacement? Should I or shouldn't I? So with the conversation with Alana Ackerman with knee OA, there's a variety of management strategies, and typically a knee replacement is one of the last options. And for a lot of people at certain periods of their life, that can be the best option at that point in time. But there's multiple things that should be considered and done and recommended before that. So if you want to dive fully into it, listen to the conversation with Alana Ackerman, watch the YouTube video that Tony was on and that you all both filmed, and then read the article. But some things to consider before going down the path of a total knee replacement is knee osteoarthritis. There should be a recommendation for exercise and movement and adjusting people's lifestyle to manage their symptoms, and try to maintain as much health and fitness globally, and then more locally within the knee joint and that involved leg. How can we improve its strength, improve its tolerance, and try to keep you doing the things you want to do as long as you can? There's a variety of other things that can be considered during managing knee osteoarthritis that we don't have to dive into here. Things that aren't recommended: stem cells, PRP injections, knee arthroscopies or meniscectomies. Those are essentially things that may be wasting time and money, aren't recommended from a research perspective. And if there's a consideration of surgery, typically the path of a knee replacement is the best option. So anything else, Mark, you feel like I should touch on from kind of that knee OA piece or discussion point before we dive into the TKA article?
No, I think you covered everything pretty well there. The general recommendation and the recommendation that you wrote in the blog is 6 months or so of non-operative management before considering TKA. But there are some nuances and considerations with that, in the sense that perhaps someone has been dealing with debilitating pain for 3 years and they've feel like they've exhausted their options. That 6 month timeline might be a little bit shorter, or somebody else, because osteoarthritis symptoms can wax and wane, maybe it's a little bit longer than 6 months. So just understand for yourself as a clinician or for a patient that there is some variability there. And it really is about what's your quality of life like. And if you're not able to do the things that you want to do at the level that you want to do them, that's going to be more important than just an image alone, right? That quality of life component.
Yeah, I've recently, this past week, had that discussion with a patient in regards to their findings of hip osteoarthritis. And I think it's a very similar discussion with considering a total hip replacement or a total knee replacement. Of this is where you currently are. These are your symptoms. This is what your day-to-day looks like. These are the things that you're currently not doing or you're limited by. Does this make sense, or does your life feel limiting enough for you to consider the surgical path? And I may use the extreme examples, but for people that I think really aren't surgical candidates at this point in time, I'll say these are the things that I think would make you consider maybe a quicker timeline on a knee or a hip replacement. You're rethinking going outside or having physical activity because your hip or your knee is so uncomfortable. You don't want to walk up or down stairs. You're limiting your social physical activities. Things in your life really start funneling in, and your day-to-day becomes very sedentary and very isolated because of how much limitation there is, even with the modifications that we try with rehab. Those are the times or the environments or the situations where it really makes sense to consider the surgical path. And I kind of bring that up to them as a lot of people, they think it's like they have some, maybe persistent symptoms, but they're still able to do the majority of their activities. But they get an MRI scan and it shows that they have these, osteoarthritis findings. I try to maybe pull them back and provide other options, or make it not so doom and gloom that they think this immediately has to occur. Is that fair, Mark? Do you have any other things to add with that?
Yeah, and I'd say on the flip side of that, we don't want to necessarily deter someone from getting the procedure who needs it. And, in addition to the quality of life, maybe the thing is, because they are so limited in their physical activity, that now they're experiencing atrophy of their muscles and, these other, I guess, side effects of this painful knee. And eventually getting that surgery might be a way to regain that strength and range of motion. And yeah, so there's always that fine balance, right, between how long do we delay the surgery. But like you said, there's a whole blog, video, other podcast episode going into that with a little bit more detail. So yeah, let's talk about knee replacements.
Yeah. So someone's going down the path or just received a total knee replacement. What it is if they're getting a full total knee replacement, there's a portion of the bottom of their thigh, the femur, portion of the top of their shin bone, their tibia, and part of their kneecap, their patella, that gets removed and replaced with metal and synthetic pieces. And if anyone ever sees a video of a knee replacement, it's a pretty wild procedure, and there's a lot that goes on. It's a huge trauma to the body, and it's a relatively lengthy rehab compared to an ACL or to these other rehabs. It's a little bit shorter, but it is a major trauma. It's a major surgery. So it should be taken seriously, and there should be kind of appropriate expectations set as to what the post-operative rehab will look like, what are some average timelines, and what are the steps we need to do from a rehab standpoint to get someone back to where they want to be and where they want to end up. People may ask, how often or how long, am I in the hospital? When we were looking up what's the average hospital stay, as of right now, 3 days is the average hospital stay. What they've talked about in the literature are these fast track TKA procedures, which essentially is this goal of expediting early ambulation within the hospital, getting up soon after the procedure, post-op day 0, meaning the day of the surgery, and post-op day 1, the day after, of getting patients moving as quickly as possible. I think there's some things within the procedure that they're trying to do to expedite the recovery and the healing, but there is some research suggesting people can leave, within 1 or 2 days. But as of right now, the average hospital stay is 3 days. There's a few things that may lengthen that hospital stay, variety of reasons. What some of the research has suggested are comorbidities, including hypertension and diabetes, longer surgical time, intraoperative blood loss, potentially blood clots, things that may extend the hospital stay, but on average, about 3 days for someone doesn't have any complications. Another kind of common question that someone may have is, when can I start walking? Like I just alluded to, nowadays it's as quickly as possible. So post-op day 0, within potentially a few hours of the surgery, or post-op day 1, the day after the surgery, you're going to have nurses, you're going to have physical therapists getting you up out of bed and walking as much as you can tolerate within the hospital. Weight bearing, moving the knee, it's safe, it's recommended, it's going to start that recovery process. It's not going to be super comfortable, but it's a very robust surgery, and it should be kind of ambulated on that knee as quickly as possible. Another common question early on, how do I monitor for a DVT? So within the hospital, there may be nurses, there may be physical therapists, and even your surgeon that discuss this with you. These things should be monitored in the hospital, but when you're discharged and you're at home, there are a few things to consider and to kind of monitor when you're by yourself or with family members. A DVT, or deep vein thrombosis, is something that should be taken seriously and would require kind of immediate medical attention. Things that people should look for and notice is in the back of the calf, any extreme kind of tenderness, any major swelling down the lower leg into the shin and into the foot, any systemic signs, kind of fever, illness, other things that would indicate there's either kind of infection locally at the knee joint or there may be a potential blood clot. Any of those, if they're found or noticed, there should be an immediate call to the surgeon or immediate drive to the hospital to investigate. So things that we just want to rule out early on, make sure someone's safe, and discuss those as a healthcare provider and for patients to be aware of.
Yeah. And like you said before, because, we're speaking about this from more of an outpatient orthopedic physical therapist perspective. Obviously, we're discussing the acute care setting in a way right now. Hopefully, if they've heard this message multiple times from their nurse or nurses in the hospital, from their physical therapist in the hospital, from their surgeon or, PA, or at least from like a packet that they've been provided about, the knee replacement. And then if needed, reminded again in this outpatient setting, and understanding that, yeah, we are looking for these, or they're looking also for these significant changes, and also creating the expectation that, hey, look, after the surgery, pain is normal, swelling is normal, like those things are normal, but these other things that you just mentioned might not be normal. And that's why it's important to monitor for those in case, like you said, a visit to the hospital is required or medical attention is required.
After that, a common question, do I need to ice my knee? When I was writing this blog, I found a Cochrane review from 2023, and that was the main kind of resource that I utilized or discussed in the blog. But they found, accumulating a variety of papers, within 48 hours after the surgery, there's some low-level evidence for the positive impact on reducing blood loss, symptom reduction from a pain perspective, mild improvements in range of motion, for icing within the first 2 days. The potential benefits, this is a quote, the potential benefits of cryotherapy on blood loss, pain, and range of motion may be too small to justify its use. So that was really the biggest, highest level of evidence I found, and it was pretty underwhelming. So I think a common theme with a lot of injuries and a lot of postoperative scenarios is ice can be a very helpful, for some individuals, helpful way to kind of numb some of the intensity of the postoperative pain. My understanding in the current literature suggests that it's not exponentially expediting this acute rehab process. It's not necessary in regards to it has to occur. If someone wants to do it, if their surgeon's telling them to do it, it's totally fine. But from an evidence perspective, within the first 2 days, there's pretty low level evidence that it has some positive impact. It's not a game changer. And if people want to continue with it, they can, but it's not something that I really personally give to patients in the clinic. They're typically already doing it on their own. So I don't tell them not to do it, but I don't spend a huge time in therapy sessions during the early rehab focusing on it. Is that fair to say, Mark?
Yeah, for some reason there's been this war on ice recently that it's going to be harmful to the healing process. Like you said, I don't really care all that much either way if somebody wants to ice, whether it's after a knee replacement or a different injury or surgery. You said it's likely not going to expedite the healing process all that much, and it's also likely not going to do any harm, right? It has a pretty negligible effect either way. If someone wants to do it 10, 15 minutes, a few times a day in a safe manner, probably not a big deal, but it's also not something that we have to strongly recommend.
Yeah. Next question, should I purchase or use a CPM or a continuous passive motion machine? I've never seen one of these in person. It seems like since I was in grad school, even the professors, there is a strong push against utilizing a CPM. And the research now suggests that in the hospital, at home, utilizing this continuous passive motion machine, which essentially looks like, if someone hasn't seen it, it's kind of like a seated, kind of recumbent bike where your feet are on pedals and you're moving back and forth. There's a strong recommendation to not utilize the CPM machine at this point in time. Have you ever seen one, Mark, or have you ever had any surgeons that still use it? My understanding is just it's way better to start ambulating as quickly as possible and utilizing other forms of gaining that range of motion than having someone just passively in bed going through this knee extension and knee flexion machine.
Yeah, I've seen a few. I think I was on the cusp of when they started to get phased out more. I might have honestly had one after my hip replacement, and I think I might have done it in an outpatient setting, which is super silly and pointless. But yeah, recently, I don't really know of anybody who's used it.
Yeah. When should I stop using my assistive device? Assistive device just meaning anything that allows you to help you with ambulating or with walking. In the hospital, post-op day 0, post-op day 1, before you're discharged, you're going to be utilizing most commonly a rolling walker or some type of walker with more points of contact, more hand support, more upper body kind of offloading. What I said in the blog and what holds true is there is quite a bit of a spectrum of who's receiving a knee replacement. And some individuals coming into a knee replacement for a long time, they've had to utilize some type of assistive device, whether it's a single point cane, a quad cane, a walker, and it's for a variety of reasons, not exclusive or not just the kind of knee osteoarthritis symptoms. They may have some balance issues. They may have previous history of falls. There's other reasons why they've been utilizing an assistive device long term. So for some individuals, after a knee replacement, even after the rehab and their discharge from outpatient care, they still may utilize a single point cane, a quad cane, a walker long-term for a variety of other reasons to maintain stability and to reduce their likelihood of falls. That being said, people that don't have a prior long history of any assisted device, after the surgery, there's an expectation that they will likely get rid of it, but there's not a rush. And Mark, I remember you and Mehmet Jem talking about this with the total hip replacement. One of the podcasts you guys were discussing, there's really no need to rush getting out of an assistive device after a hip replacement. And I think that holds true for a knee replacement as well. I tell patients that there's a variety of factors that we want to consider before you're, going down one level or another level, whether it's going from, a rolling walker to a single point cane or to nothing at all. And we don't need to rush that timeline. We want your gait to look relatively normal. We want you to feel stable. This doesn't need to be an expedited process. So there's a big range of when people will remove an assistive device, if at all. Generally, I would say on average in an outpatient orthopedic setting where someone's relatively physically fit, they didn't use one in the past, I would expect between 1 to 2 weeks on average, people will wean from a rolling walker to potentially a quad cane or a single point cane. And some people may linger a few weeks after that, but it's within a few weeks span and it doesn't need to be rushed. We want to make sure that they have kind of appropriate offloading and appropriate stability to manage the surgical limb. Anything you would add there, Mark?
I think sometimes people are in a rush to get off of the assistive device or assistive devices because how they perceive it to alter their identity. Meaning, same thing with the surgery. Like, they might not want to get a total knee replacement because they perceive themselves as getting older or less capable. And same thing with an assistive device. Using that to get around, that might change the way that they think about themselves, or they might think that it's going to alter the way other people think about themselves, think about them. And I understand that. Like, it's surgery's not easy. Having to change how you walk or move isn't easy. But the purpose of this assistive device is to, one, the most important thing is to keep you safe if needed for safety. And then two, to help you normalize your strength and range of motion and swelling, and really to get you back to your full function, hopefully without the assistive device. So using it for the appropriate length of time will actually get you back to what you want to do quicker than trying to rush off of it as fast as possible.
Next question, what should I expect my knee range of motion to be? This is very helpful early on to discuss what are the averages that a patient should be aiming to look to, and what would we expect from a timeline perspective. There's a variety of kind of practice guidelines or protocols from a variety of hospital systems. And on average, what they shoot for or expect is this 0 degrees, meaning the knee is fully straight, knee extension, to about 115 or 120 degrees of knee flexion, so the ability to bend. That is a really good average. For some individuals, they're going to shoot past that and it's going to be a relatively quick process. And for other individuals, it's going to be a grind getting to that 115, 120. And there's a variety of reasons as to why that may be the case. What I found from a research perspective, there was this reference chart that I thought was super helpful. And when I was looking up and writing this blog, when I found it, I actually started using it with patients in clinic to discuss with them. And it gave me a little bit more clarity, but it's by Kittleson et al. In 2020. And they took 327 patients post-total knee replacement and tracked them. I think it was up to, I believe, 60 days. And it showed these percentiles of during the rehab process, how is knee flexion range of motion trending, and what is the average, what is kind of the top 10%, and what is the bottom 10%. And around the 2 to 3 month mark, knee flexion tends to plateau, and at 50 percentile, the average was around 115 degrees. So it kind of aligns with some of those hospital systems protocols that you'll see commonly. So if someone looks up post-operative total knee replacement Rehab, you'll see Ohio State, Delaware, Brigham and Women's. And this group for this study that tracked over 300 patients, it kind of aligns with that. I will tell my patients that's the average, about 115. I'm hopeful, and my goal is to get us closer to 120 to 125. There's a variety of daily activities that you at least need a minimum range of motion. But for athletic endeavors, getting back to well-structured resistance training of the lower body, it's helpful to have more range of motion. And I think 115 is, I would say, the bare minimum, but hoping for 120, 125 is kind of my goal with each patient. Any thoughts there, Mark?
Did you read anything about expectations from patients as it relates to kneeling, whether in that study or elsewhere?
No, it's a common complaint that I know a lot of patients postoperatively will discuss, that it's extremely painful to return back to kneeling, or they'll ask, how long will it take for me to return to kneeling? And I didn't, when I was looking at this blog or looking into writing, there wasn't anything that I specifically found from a kneeling perspective. Are you aware of it, or what would you typically say?
I'm not aware of any research. I can't say that I've tried to find research about the topic recently. And then I don't know if we can definitively give an expectation on what's reasonable, right?
Mm-hmm.
For the most part, there shouldn't be any reason that they can't kneel from the actual, let's say, stability of the joint perspective, but it really is about the ability to tolerate that. So we can't determine if someone's going to be able to, we could try to create some kind of structured program to improve their tolerance to that, but not that it's not important, because it is, maybe people want to kneel for gardening or playing with grandkids or for religious purposes, but there's so many things that need to be accomplished in rehab as it relates to getting the knee straight, getting the knee bent, getting that quad function, walking, going up and down stairs, that it's hard to maybe make that a big component of rehab, unless that's a very, very important goal for somebody. It might just be a discussion about a general strategy of maybe trying to desensitize that area over time if needed.
Yeah, totally. There's a few weeks ago, I did have a patient ask, and I laid out, if you wanted to get back to that, what some of the steps would be. And I talked about being in a quadruped position or on all fours, utilizing some offloading from the upper body, having the knees supported with, a TheraPad, pillows, etc., working on weight shifting, working on rocking back, increasing the duration that you're in that position, reducing the cushion over time, reducing the support. So I've discussed that, like you mentioned, but as well, I don't spend a lot of time in the clinic, at least at this point. I'm sure there's scenarios for maybe someone has to return back to a specific job that requires a lot of that, or situations where in the clinic we should be more honed in, but there's so many other kind of priorities that it's more of a talking piece on how to do it on their own. How long will my knee replacement last for? These studies, they seem to be kind of clumped together with total hip replacement. And there was a big one that I think, Mark, you referenced in a few of your THA blogs and YouTube videos. But on average, there's a range, but on average, about 20 years, 15 to 25 is what the substantial majority of total knee replacements will last for. There's a variety of things that may make someone need another surgery sooner than that. But typically, if things are smooth after the rehab, they don't have any complications, on average between 15 to 25 years. And I'm pretty sure that's very similar, if not the same, from a hip replacement perspective, right?
Correct.
Yeah.
Yeah, like you said, I know you pulled some of those stats from the Evans paper.
Mm-hmm. Yeah. Is resistance training safe after a total knee replacement? Yes, we'll dive into it in a little bit in regards to what does post-operative rehab look like. But a big portion of rehabilitation is returning the strength, the range of motion, the function and the capacity of the knee. And a lot of that involves progressive loading, starting with some body weight, some modified positions, but eventually adding external load. So yes, it is safe and it's recommended, and it's going to occur in someone's rehab. Can I return back to sport? This is somewhat of a messy question. And I remember kind of the conversation you had again with Mehmet on this from a hip replacement perspective. So if you want to add any of your thoughts as well, Mark, I'd love to hear it. But there's kind of this common theme that high impact sporting activities, it can increase the likelihood of a quicker need for another procedure, or quote unquote kind of wear down the replacement. And there's a revision that may need to occur sooner. When I dove into literature, there wasn't a ton of literature actually tracking that, of people that were in high impact sports and they were at a shorter timeline or quicker timeline of needing a revision. It's more so a commonly advised against activity of major, consistent, high impact based sports or activities. What is commonly recommended and okay are lower impact sports and activities, whether that's swimming, golfing, cycling, walking, things that are classified as intermediate impact. And the study that we looked at defined that as hiking, mountain climbing, downhill skiing. They said that about 64% of individuals after a knee replacement got back to that. Shockingly, in this paper, high impact sports, including running, tennis, and ball sports, have a 43% return. So I would say that's still a relatively high number for people that did that in the past. But there's other papers that have a strong recommendation against high impact activities, or you'll hear surgeons strongly recommend against it. I think ultimately taking into account what your surgeon's explanation is for what they are or not recommending, what your previous activity level was and what you were doing prior to the surgery, and your level of tolerance or with risk or uncertainty about what this may do to the timeline of your replacement. What are your thoughts there, Mark? I think it's hard to have a concrete yes or no for a lot of activities. I think given what we currently know, telling the patient, the surgeon's recommendations and their own personal values and beliefs as a patient. But I think ultimately they should have the decision of whether or not they want to reintegrate back to a specific, maybe higher risk or higher impact activity.
Yeah, I have 3 thoughts with this. So one, I haven't read this paper specifically, but sometimes when they discuss returning back to sport, it's a subjective reporting from the patient, right? So if a patient says, hey, I've returned back to running, tennis, or ball sports, like let's say they've returned back to basketball, doesn't necessarily mean that they're doing 5-on-5 full court. I see some people at the gym who are playing basketball, but they're kind of just walking corner to corner and shooting like 3-point shots. So keep in mind that there is a spectrum of what it means to return back to a specific sport. I will also say, from an anecdotal perspective, I'm not sure if I've ever had a patient after a knee replacement ask about getting back to running or high impact activities, really, just based on their previous level of function and what led them to get the knee replacement at the time that they did. They're usually happy with the walking, cycling, hiking, golfing, things like that. How about you? Have you ever had a patient say, hey, I want to get back to running?
Not yet. There's been a few situations where patients really want to get back to more intense mountain climbing. I know one of my colleagues at my prior job, one of their patients was in like a 70 and up men's basketball league, and he got back to that. But again, what that looks like is, again, a spectrum of what basketball is and the demands and the velocities that they're at. But I haven't, not yet at least, had a patient ask or request to get back to running in particular.
And then the third thing that I want to bring up is that I think I have a slightly different opinion to Mehmet about returning to higher level activities. And I'm going to try not to misquote him, but I think from our discussions that we've had and other information that I've seen from him, he usually advises people after, total hip replacement, hey, if that's something that you want to do, the whole purpose of the surgery is to kind of give you this new lease on life, go and do it. Like, life is short. This gave you your function back. Go use it to its fullest capabilities. And while I understand that and I appreciate that and I agree with that to some extent, I also want to share the potential risks associated with that and the fact that we don't have a lot of good long-term data. So if someone asks, hey, can I return to playing basketball after having a knee replacement, I might say, well, we don't have a lot of long-term data, depending on the volume, the frequency, the intensity of the basketball that you're playing, there is a potential that that level of basketball reduces the longevity of that knee replacement. But I can't give you any real stats one way or the other of how it's going to influence it. I'll say, physical activity is good and you should remain physically active. But I'm not sure if I would just say, yeah, go back to doing whatever it is that you want to do, because there has to be, if someone said, hey, can I go back to parkour, right? We're probably going to say, maybe you shouldn't be doing parkour, right? So there has to be some cutoff or some kind of discussion that we have about this. There's just not going to be a very educated discussion based on specific research. You have any thoughts on that?
Yeah, I agree. I appreciate you providing that clarity. I'm sure as I go throughout my career, there's going to be patients that are going to want to maybe push it to more of higher demands. But at this point, it's primarily been, they just want to get back to some type of consistent exercise routine, some type of maybe consistent hiking and walking and cycling and swimming. And that's about it. Let's rock and roll with the rehab itself. So the last question I posed in the blog is, what will rehab actually entail? And some of this we've already covered, and there's a lot of fluidity to this. And again, like I mentioned with an assistive device, there's a big spectrum of people receiving a knee replacement, where they're at in their life and their stage of fitness and health. And so this rehab may look drastically different from a 65-year-old, extremely fit, high level of function individual that wants to get back to a variety of activities versus an individual with potentially a lot of comorbidities, was relatively sedentary before, had a high, frequency of falls. Their end goal or their rehab and their kind of plan of care may look very different. Early on, these post-operative first few weeks, the priorities are all the same. But as we go down into, month 2, month 3, long-term, what people are doing for training or exercise is going to look pretty different. So we'll discuss that as well. But within this first phase, and what I utilized and what I mentioned in the paper or in the blog is I utilized a specific protocol that was already online. I actually don't have it in front of me. I believe it's either Ohio State or University of Delaware. I want to say Ohio State. But what I caveated or mentioned in the blog is, your surgeon may give you an initial protocol or your physical therapist may have one. So some of what I'm saying may sound very similar, but some exercises or timelines may be a little bit different. But there's a lot of great kind of protocols or rehab templates. But if they're achieving these big principles that I discuss, then I think everyone's in a good spot. So early post-operative, week 0, all the way up to around the 4 to 6 week mark, these priorities are going to be true for everyone coming in. Early on, I'm educating a patient, and this can also be pre-operatively. We didn't touch on it, but there's a huge value to, before the surgery, having 1 or 2 visits discussing the post-operative priorities. So discussing this either right before the total knee replacement or within the first few treatment sessions, the initial big rocks. Number 1, and some of this doesn't go in a specific order because these are all very important. But number one is, again, discussing the things that they should be monitoring from a blood clot, a DVT, an infection, all of these signs and symptoms that would indicate kind of immediate fast track back to the hospital. Just re-emphasizing those, like Marc said, they've already been brought to their attention through nurses and the surgeon, but reinforcing those after the starting orthopedic outpatient rehab. Number two is emphasizing regaining range of motion. And I kind of chunk it out. I start with extension. How do we prioritize this in the clinic and at home? And I'll have them prop their heel up on, typically it's like a yoga block, but it can be a towel. And I discuss with them the value and the necessity of getting this knee extension back as soon as possible. And I'll give rough kind of ranges of what I would look for over the course of the first few weeks and within each day of how long do we spend in this knee extension position. But I tell them the goal is to get that knee to at least 0 degrees of knee extension. And it is compared to the other side. Some individuals have symptomatic knee OA on that side. Some people have already gotten a knee replacement. So some of that, people, if they're low function or low range motion on the other side, you want to use the average of at least 0 degrees of full knee extension. But I tell them the importance of getting the knee straight as soon as possible. And I'll emphasize at least 45 to 60 minutes throughout the day. And I'll say cumulatively. I don't know if I didn't find any research on this. And I'm curious, Marc, if you know, but this was just a consistent theme in my first clinic of utilizing about an hour, but 45 to 60 minute range cumulatively by the end of the day of just propping up the heel. I think if it was lower than that, closer to 30 minutes, I'm sure it's enough. It was more, it's fine, but I would rather recommend a little bit more and people undershoot. But I say prop up the heel so the calf is floating and the knee is being pulled down by gravity into extension. This can be broken up early on into a few minutes at a time, into 10 minutes. It's not going to feel super comfortable having that knee propped up because they're immediately after the surgery and it's going to be pretty painful. But I'll reiterate the importance of getting to 0 degrees of knee extension or full knee extension as quickly as possible. And I'll have them ask any clarifying questions. The second thing, regaining the ability for the knee to bend. This is a little bit more of an active process. Typically, I like either a laying down or a seated up, seated with back support, heel slide with strap assist. So I'll tell them at home, if you have an actual strap for this, if you want to use towels, if you want to use bed sheets, anything that you can bring around that forefoot, and you use those arms to help the knee bend as much as it can tolerate. I'll again provide them the reassurance that it's not going to feel super great. It's not comfortable. Your knee's super robust. This is a super stable knee and surgery, but we need to bend it. And I'll tell them kind of the sets and repetitions throughout the day. And I tell them this is also kind of a volume game, multiple times a day, 10 to 15 repetitions, find that end range. And our end goal, like I mentioned earlier in this conversation, is 115 as a minimum. I would love to get to 120 to 125. Go ahead.
Let me ask you a question here because you've mentioned it twice with both regaining knee extension and knee flexion. You have a patient, you see 4 patients today. One of them's patellofemoral pain, one's patellar tendinopathy, one's post ACL reconstruction, and one's a knee replacement. Is your acceptance for pain or soreness different for the knee replacement, or do you expect people to have more soreness or pain throughout this process as opposed to maybe some of these other diagnoses, non-surgical or even surgical diagnoses?
Yeah, typically total knee replacement is the most painful knee procedure that I'll commonly see. There's definitely been some ACLs or patellar tendon repair where they're not having a good time getting that knee to bend or throughout the rehab. But I think I have the most lenience for how much pain they're in, especially with this kind of active assistive knee flexion. I'll tell them and they'll experience it pretty quickly. I'll say, the bad news is that this is really uncomfortable when you're bending that knee. The good news is it's very transient. As soon as you get it out of that position, it's alleviating. And I'll tell them during the activities that we perform here and at home, that's what I would expect. It's when we're having those symptoms last for a really long time, or it's really impacting your ability to continue to walk, or we've just overdone it. That's when I want to know. But within the moment, I'm very comfortable with quite a bit of knee discomfort during knee flexion range of motion. I've never had a patient that is not grimacing or not super happy with me, or they're typically kind of pissed off because we're bending the knee. But yeah, I think knee replacement for sure is something that I just have more wiggle room with from a discomfort perspective. Would you agree, or do you have other thoughts?
Yeah, I agree. I think setting those expectations early are important, right? Maybe I know you talked about it with knee OA probably, but like sore but safe, and then making sure that it's not this unreasonable amount of pain, or obviously we're trying to manage a swelling, which I think you'll touch on, but also I'm sure we both have, and a lot of the clinicians listening have also worked with patients who maybe didn't get that push to regain their range of motion early, and then trying to play catch up later on is not, it's a much less fun experience. So, allowing some level of discomfort early on kind of saves you in the long run.
Yeah, totally. I've also found that the patients that have come in for a few preoperative visits before the surgery, either they wanted to do it or their surgeon referred them, their knee's not going to feel super comfortable with their knee symptoms preoperatively going into knee flexion. So I already get them used to the idea and habit of bending the knee, and they already know that it's not super comfortable. Obviously, it's another level after the knee replacement, but I think that's really helpful is if someone's able to do it preoperatively and get used to this idea of like, okay, my knee's irritated when I do this, but it's safe and it's okay, and I'm going to do this immediately after. For the patients that I've had preoperative care, it seems like it's still not fun for them, but they just like grit their way through it, and they know that it needs to be done. And like you said, there's been multiple patients, especially recently, that I've taken from, I've adopted their care. They were either in home health initially, or they had physical therapy and then they kind of like self-discharged, and they're now showing up 4 months out and they still have, or they only have 110 degrees, or they have 100 degrees of knee flexion. Trying to normalize that knee bend at that point is substantially harder. And I think there's a lower likelihood of it returning. So knee extension, knee flexion, range of motion priorities I hit at. Swelling and kind of symptom management, I tell them that the knee's going to be swollen for quite a while, and it's not going to be super comfortable for quite a while. It's a fine balance between allowing the body and the knee to rest, but also pushing and creating activity throughout the day over the course of the next few days and the next few weeks after the procedure in what your system can tolerate. So again, depending on what people's level of function and fitness levels are going into the procedure, this can look very different. But for some people, it's like post-op week 1, we're mainly hanging out in bed. We're going to outpatient physical therapy. We're potentially getting on the bike. And we're doing maybe a few bouts of slow walking for a minute or two around the house. But that slowly builds over time. And I give people the autonomy of, as you start feeling like you have more energy, you are getting kind of stir crazy on the couch, just start walking more and more throughout the house. And it's this building that what they can manage over the course of multiple days and multiple weeks after the procedure. So it's reassuring them that swelling is going to be there, but we don't want to do too much too soon. I typically find that it's the opposite. I'm curious, Mark, if with your perspective, but I rarely have patients that are doing way too much too soon. It's typically people are in a ton of pain and they're not doing enough, or they're too cautious. So it is a balance there. But it is reassuring them that we need to move. And as your body allows, let's increase the daily activity levels outside of what we're already doing in PT. Another more specific recommendation or consideration is regaining the strength of that quadriceps muscle and the entire leg as a whole, but explaining to the patient the impact that the quadricep has on the function of the knee, and how after big surgery that quad doesn't want to work, and how we can do things throughout the day to kind of wake up that quadriceps. And it can be early on, or as early on as post-op day 0, as many times as they want throughout the day, just squeezing that quadricep and contracting it, introducing some lower level, long arc quadriceps activities, short arc quads, doing wall sits, things that just stimulate some level of quad contraction. I discussed the importance of that and what they can tolerate at the house, and how, again, that's kind of a frequency game of squeezing and trying to utilize that quad as much as possible to start waking it up can be really helpful. Those are pretty much the big priorities. I also put improving confidence and competence with daily activities, but a lot of that goes again to, as they become more comfortable and ready to engage with activities around the house, they'll start doing so. And I don't really push them or force them to do anything too soon. Normalizing walking quality and speed, I said, is another priority. A lot of these goals, they're kind of accomplished at the same time with similar interventions. With, if we can normalize the knee extension, regain knee flexion, and get that quadriceps to wake up, the walking quality and the speed itself is going to improve. Anything else, Mark, you would add to these kind of initial 0 to 6 weeks, phase 1?
No, I just want to reiterate what you just said in terms of really getting good at the basics. And, because like for the walking thing, like, sure, you can add in walking drills eventually, but if you're not managing the swelling and you're not getting that range of motion back, all the walking drills in the world aren't going to do that. So the better you get at some of the other things, the better the walking is going to be. Like you said, they all go hand in hand. Foot and foot.
Trying to do force a high quality or a high looking, heel to toe, knees bending, a controlled gait, and you're trying to do it over hurdles or something in rehab in the clinic, but their range of motion is still at 70 or 80 degrees. That gait is still going to look wonky until you can improve that knee bend. So it is hitting those low level or early on priorities before trying to jump multiple steps. Phase 2, again, this is very fluid, and there's not this, we're on week 6, we're going to have a hard transition. The day to day and the week to week, it's very gradual changes, and things are put into the plan, things are slowly taken out. Once people's range of motion normalizes and it's stable, that frequency and that duration of knee extension, heel prop, or heel slides moving into knee bend, those things just slowly move out of the plan. And there's other things that take priority. But just because I say phase 2, it doesn't mean that this is a completely different look to what someone's doing at home or doing in the clinic. The priorities between the 6 to 12 week mark, there is some kind of gray area there, but the priorities are, hopefully someone's achieved full or near full knee extension range of motion and knee flexion range of motion, continued improvement of the quadriceps strength, the intensity and the quality of the contraction, and the whole strength of the leg as a whole. Their gait quality and their speed is somewhat returned to normal or improved, especially if right before the surgery they were really struggling or is a really antalgic gait. And then tolerance to daily activities, these ADLs of, if they have stairs, if they have whatever is in the house, they're comfortably able to do the majority of their activities at home. Cooking, laundry, getting up and out of bed, using the restroom. These things should feel pretty normal and not like there's a big struggle. Within these 6 to 12 weeks in the clinic, the priorities of early range of motion, some level of protection and management of swelling, and lower level resistance-based activities, this is starting to increase with the external load applied to the system and their body, the maybe expansion of the different types of activities for the lower body, the intensity from the weight perspective, and the total volumes may uh, increase. And again, this is very different each person depending on what their end goal is and really what they're currently at. And within our YouTube video and within the blog, we kind of give an outline. So I don't think it's necessary we dive into a whole plan, but someone at this point within week 6 to week 12 should be doing a relatively like comprehensive lower body resistance training program, some type of squatting, maybe modified still to a chair or to a box with some external load, some type of split squat position, whether that's a step up, whether that's an assisted stationary split squat with hand support or with external load, some type of isolated knee extensor activity with a loaded knee extension, something isolating the hamstrings, things that start to look like someone's integrating back into a well-rounded lower body resistance training routine while still making sure and monitoring the low-hanging fruit are still there and aren't being lost. So making sure the range of motion is where it should be, checking in on the knee extension strength and the quadriceps tolerance and capacity, and that overall they're becoming just fitter as a human and that whole leg is improving. Anything within that kind of mid phase of rehab that you want to touch on, Mark, or you want to add to?
Yeah, maybe it's not the case as much in our smaller circle, but in general, I don't know if there's any joint like the knee that gets looked past so often, meaning there's a knee issue and it's, well, we got to look above at the hip, we got to look below at the ankle, and not emphasizing enough the muscles that directly cross the knee. And so, yeah, it's important to train the hips. It's important to train the calf and the ankle and the foot, but especially with total knee replacement rehab, I think the ceiling for quadricep strengthening is often the quad sets, the straight leg raises, the short arc quads, and the long arc quads. And then there's nothing beyond that. And yes, squats are integrated, step ups are integrated, split squats are integrated. But you and I both know that there's not necessarily, especially in a case like this, there's not necessarily a replacement for just an isolated knee extension. There are ways to compensate during a squat or a step up, whether it's due to range of motion restrictions, pain, swelling, inhibition, etc., that really regaining or improving that quadriceps function to better than they even had prior to the surgery just makes all of those other activities, the squatting, the split squatting, the stairs, the hiking, that much easier, especially if, we discuss going back to some of these higher level activities. It's just so important.
Yeah, in my last clinic, I, even though it's a knee replacement and maybe people have different views of what testing may look like, but I would still isometric test knee extension, kind of peak load and peak tolerance for my higher level knee replacements. There's some individuals where it wasn't appropriate or they kind of self-DC'd because they were back to their daily activities. But a lot of these patients that are active and want to get back to consistent resistance training or hiking, or I had a few patients that were flight nurses and they had to get in these really somewhat compromised or positions or had a lot of situations where they needed to potentially produce force quickly, and they probably needed more access to strategies and options that would be required for their job. And having more force production at the knee and more quad strength and muscle mass is extremely valuable. So there are multiple patients where I would assess limb symmetry and their total force output and compare it to body weight. And I wouldn't baby them just because it was a knee replacement. So I still, like you said, I think isolating, making sure that there aren't these huge discrepancies, especially during this mid to late stage rehab. And if there are, they're just going to start, like any other knee rehab, they're going to start utilizing other strategies and other muscles to accomplish their goal. And we probably should get them as fit and strong as possible to be able to resource or to utilize the quad and not have to continue to rely on those other tissues. This last phase, there's again a lot of wiggle room. I looked back at the blog. So this is from Ohio State's protocol, total knee replacement, and their recommendation or their statement that I believe I took from them of their 4 priorities or goals during weeks 12, so 3 months onwards: full return to prior level of function or beyond. Again, at a bare minimum, we're getting back to the point someone was pre-surgery, but a lot of times people are receiving this knee replacement because they've lost a significant level of function. So hopefully we're getting above where they were pre-operatively. Restoration of your quadricep strength and entire lower leg. Again, I think there's a lot of values to still isolating and testing the strength of the knee extensor and potentially other muscle groups or other either outcome measures or performance tests that indicate that we've improved these qualities in an isolated manner, and then it's integrated into their life. Number 3, initiate progressive plyometric activities per the clearance of physician. This is where there's a huge spectrum. Number 4, progressively return to sport or recreational activities per the clearance of the physician. So 3 and 4, there's a lot of people that just aren't going to get here. They don't want to get here. It's not safe for them. But for individuals that maybe do want to integrate back into pickleball or tennis or some pickup basketball, maybe these aren't extremely competitive activities, but they still have more demands than daily life or just going and swimming. So knowing and appreciating what people want to get back to, at least having a progressive plan, appropriate progression to help them get to that. So in the video and in the blog, I give kind of 2 options of what an end stage rehab could look like for someone who is just doing day-to-day activities or some light exercise after discharge, and someone who may want to do something more demanding on the knee, whether it's a sport or kind of valued life activity. I'll give both options and I'll describe why they're a little different. So the first one is this individual that's just doing day-to-day activities or light exercise. I wrote speed-focused squats, speed-focused step-ups, weighted squats to a chair, single leg RDLs, weighted split squats, deficit single leg heel raise, and your aerobic activity of choice. This is, again, there, even for this individual that may not be getting to a lot of intense activity or higher velocity activities, there's a ton of value to still improving and incorporating a higher velocity component or a higher intent activity to reduce the likelihood of falls in the future or to mitigate some of this power loss that occurs as we age. So in the video or in the blog, if anyone watches or reads either one, there's value to incorporating to a patient something that has a higher speed component, whether it's just sitting on the chair and trying them to stand up as quickly as possible or stepping up on a box as quickly as possible. I think even if it's the person that's just going home and wants to live their day-to-day activities, explaining the value and incorporating the demand of higher speed activities is super useful. And then again, just a well-integrated resistance training plan that trains the majority of the muscles in the lower body. The things that potentially change for someone who wants to get back to tennis or pickleball or maybe is considering running or other activities is maybe providing them options of kind of lower level plyometric entry activities. So I put double leg pogos. This is more of an ankle strategy. It's not extremely demanding on the knee or the quad, but it's at least getting them some adaptations in the Achilles and in the calf that may be beneficial for what they want to enter or integrate back into. And then I put box jumps where it's not a super intense plyometric. You could argue it's not really even a plyometric, it's just a jump, but you're raising the floor and you're decreasing the kind of vertical landing forces because you're landing on top of a box. So things where power output is high, but it's not a depth jump, it's not a counter movement jump, it's not something that's extremely intense from a load perspective on the deceleration aspect of the knee, but it's getting them to move faster, have a little bit more athleticism, and at least just start to integrate into some of those qualities if they want to get back to more demanding activity. I put snap downs as another example of you're improving or working on the ability for them to decelerate quickly, but it's more of a controlled, safe position. It looks very different for someone going back to high level sport and a lot of these other rehabs, but I think that's a reasonable thing for someone potentially to work into. What are your thoughts with some of those activities, Mark?
Yeah. So obviously, everyone listening, this is always going to be a nuanced discussion and consideration with the person in front of you or the surgeon or whoever it might be. But to give a simpler example, it's being inactive, taking the extreme, completely inactive. The potential deleterious effects of that is infinitely more harmful than anything that might be happening at the knee when you are being physically active with walking and resistance training, right? So what I'm saying is that some people are worried, like, oh, am I going to wear out my knee faster if I do some squats and step ups and whatever else? One, I'd argue no in the first place for that. But two, like the benefits of being active far outweigh the benefits of being inactive, even taking the knee replacement into consideration. And the same thing that you mentioned with whether or not someone returns to sport, that power component, the risk of a fall in older age probably outweighs the risk of some of these exercises that you're describing. Like we know the risk of falls, especially if it leads to a fracture, of the hip. And so having that power, being able to react to a perturbation or a loss of balance is very important. So that can be something that is a consideration for everyone. And once again, there's nuance and there's just some people that aren't going to get to that. And there's going to be some people who are on assistive devices for the rest of their lives potentially. And that's fine. This is a spectrum here. But I thought you brought up some really good points.
Yeah. And then just finishing, that person that wants to get back to more demanding or more athletic activities, it's the same priorities of still maintaining and improving general strength levels within the whole lower legs and the surgical limb, but still focusing on the strength of the quadriceps and isolating it, but still having a full, well-rounded program. Both of these plans, and I think long-term, the goal as someone discharges from care is to make sure that they have a long-term plan and an idea of like, what do I want to get back to? And have I gotten there? And if not, how can we get you there if it's appropriate and makes sense? And from an exercise, a long-term perspective, are you open and willing and interested in continuing a resistance training plan? Can I successfully set you up with an idea of what that could look like at the gym, at your house, outside, etc.? Are you open to continuing with cardiovascular exercise and aerobic activity? And what could that look like for you? And what do you value? And how can we keep that a realistic, have it be realistic, but have it be a consistent part of your day-to-day or your week-to-week? So once someone's discharged and they're through physical therapy, they're not just stopping all activity, because that's where the concerns come of losing the qualities that they had, losing some of the range of motion and the strength, maybe starting to have symptoms other places because the health benefits aren't just improving or maintaining that surgical limb, it's keeping the entire body as kind of fit and active as possible going into the rest of their life. So best case scenario, someone leaves in a really good spot and they also have an idea, how do I maintain or continue to improve on this momentum moving forward?
Chris, I think the majority of the revisions I've seen have come from infections or, some kind of catastrophic event. In the case that a patient asks you, what can I do or what should I do to maintain the longevity of my knee replacement so I can be that statistic that lasts 25 years or longer. Do you provide any advice there?
Yeah, it depends on each person and where they're currently at, but a lot of times it's that recommendation of maintaining either what we're doing or what we've done in the clinic, or providing the bare minimums from a physical activity guidelines perspective of at least 2 times a week of resistance training, full body, and at least 150 minutes of moderate intensity aerobic exercise. And telling them if they can accomplish these more general fitness and physical activity aspects or guidelines, then they're in a really good spot. And I'll discuss some of these other priorities or things that they consider from a body mass perspective and dietitian or nutrition standpoint, and other things in their life that will help reduce the likelihood of adverse events or of a fast track potentially. But outside of that, I don't really give any other specific advice. That was a lot. I think we can call it there. If people want to dive into more specifics of the phases, if they want to have resources, we have the blog, we have the YouTube video, we also have the knee osteoarthritis blog and the video. I think this should be helpful for clinicians and also for patients.
And if you're someone who wants to discuss your case more, we do consultations, so always happy to answer any questions there.
Yep. All right, we'll call it there. Thanks, Mark.